welcome to the session that's right after lunch. Always the one that is hardest. I'll try to take a page out of Angie's book, and I also tend to have a very kind of calming voice. I used to teach yoga. So I will try my best not to put you into nidra sleep right now. All right, well, welcome back from lunch. I hope everyone enjoyed it. My name is Dr. Marilyn Lynk. I am the Executive Director for Equity, Diversity, and Inclusion at Adventist Healthcare. We are located in Gaithersburg, Maryland, and I'm very glad to be, thank you, woohoo! Maryland is in the house. Glad to represent our system here today, along with my colleagues. And I am going to introduce to you two wonderful colleagues from Advent Health in a moment. But I wanted to share with you, before I came here, I read an article in Healthcare Executive by the title, Health Equity is as a Patient Imperative. And it starts out with a statement that says, it is clear that healthcare can be provided, but the care provision that is equal and equitable, it's not the same, right? And it kind of invoked in my mind this graphic from Robert Wood Johnson Foundation. Have people seen that graphic? Raise a hand if you've seen it. Well, you have been to cities and other areas where you've seen these bicycles that they have now near a metro stop so people can start riding bikes in different areas. You can see the city by bicycle, and they're all the same. So in this infographic, they show bicycles that are all the same, and that's what equal means. Equal is the same. And equal care is providing the same treatment. But we recognize that not everyone comes with the same resources or the same backgrounds or cultures or needs or preferences. And so what we aim for is equitable care, care that doesn't vary in quality because of one's characteristics. And we've talked about a few: social determinants, health access, social determinants of health like housing or transportation or food. We know that patient-centered, culturally competent care is care that is respectful of and responsive to those needs, whether they're socioeconomic needs or beliefs or values or preferences. And so it's my pleasure to introduce you today to two outstanding leaders at Advent Health who will talk about health equity today. So we'll start with a colleague of mine, Jessica Brazier, who is the Chief Diversity and Inclusion Officer for Advent Health. She and I served on a work group for the Adventist Health Policy Association. And if you haven't seen it yet, working with Carlisle and with Jerry and with other colleagues, there's a health equity, achieving health equity through racial justice statement that you really should take a look at. A lot of hard work going into the reason why we do this work and the guiding principles that you can follow to achieve health equity. And joining her today will be Dr. Alric Simmonds, who is the Chief Health Equity Officer for Advent Health. So please warmly welcome our speakers today. And we're going to do this a little bit differently. So I have two speakers. I figured this is a great opportunity to have a panel conversation about this topic. But I want to start out and ask each of you to just talk about your personal story, your journey about how you came to this work, and of course your perspective about health equity.
Testing? Yes. Oh, that's working good. No. How is this? Wonderful. We can hear now. Thank you, Dr. Marilyn, first of all, for that introduction. And I am Jessica.
To the question of how does the work of health equity tie into my personal story, I have to tell you, it's just my lived experience. I am a first-generation American. My family is from a small island called Nevis. How many of you have heard of Nevis? That is much better than the answer I usually receive. Wow, a very small island in the Caribbean. I'm talking about a population of just over 12,000 people, smaller than most small cities, right? And we moved here from the island of Nevis. I, of course, was born here in New York. I'm in a very diverse, multicultural family. And from the time I was young, I saw how circumstances of race, class, culture, disability, socioeconomic status, all of those things intersected with the day-to-day realities of individuals in my family, individuals in my community. And this is very much aligned to the work that we're striving to address every single day as healthcare professionals. And then you add on the layer of when you're part of a multicultural family. I mean, my family, it has everything from black to white, everything in between, different nationalities, different religious backgrounds, different political beliefs. You sometimes have that situation where worlds collide. Remember that movie Crash, where people whose lives would typically never intersect are suddenly intersecting? And that's the reality of my family. And sometimes it could make Thanksgiving dinner conversations very interesting, if you can imagine. And so I've always wondered, how can we learn to live and love together in spite of stark differences? And I've served in a bridging role even within my family. And the word bridging, it's actually now a concept in industry, but how we can move from an identity-based persona to that collective we that identifies those differences we have, but in a way that shares empathy and that has a stake in one another's journey. And that's where we are with my family. We don't always agree, but there's empathy. We believe we have a stake in each other's fulfilling lives, and that's the work I'd like to do even more broadly as we move around towards the health equity work for Advent Health. So Dr. Simmonds?
Good afternoon. That's that post-prandial after lunch burn. Good afternoon. There we go. Now I know you're with me. So I'm Alric Simmonds, and have the pleasure of being the diet partner to Jessica. My why around health equity really started in med school, if not before. I too am from the islands. I'm born in St. Croix, United States Virgin Islands, and my mother came up as a nurse. She graduated from nursing school in Ponce, Puerto Rico in 1962 to Washington, D.C. to complete her anesthesia training. So I was educated by a nurse, so let's get that correct. Great respect to you. But really and truly, I found it striking. I fell in love with medicine. And I remember in the second year studying pathophysiology. And every part of pathophysiology has a small chapter on the epidemiology of the disease. And irrespective of what disease you studied, there was typically a carve-out that said, this race dies more frequently. Though it has less exposure or less incidence, the prevalence of mortality and morbidity, and frequently it was African Americans or Black or other minority populations. And then when we got involved in our clinical rotations in the third year, I was at Ohio State and got involved with the African American Breast Cancer Survivors Group. And I found each one of these women had just incredible stories of bravery and loss. And they all had a story, and many of them involved some degree of lateness or mistreatment or lack of respect. And then the other thing that really got me started back then, we had a student organization, the Student National Medical Association. And back then, the Ohio Commission on Minority Health was putting together this movement where if you were receiving WIC funds, if you were receiving federal aid, and you had more than 3 kids, they wanted all of the women to have Norplant inserted in their arms. Right, I had the same effect. It's a company. And so we got together and started writing a petition. We took this to the Ohio Commission on Minority Health as students, and really, that was my first real state-level activism. And so progression of events, seeing and interacting and really being poured into and educated by women and their experiences with breast cancer, and then these other atrocities about choice when folks were poor and needed government assistance. Here at Advent Health, we really have been on a die-hard journey in this space probably since 2015. Myself, Cheryl Moorhead, Burger Lee Swanson, who used to be the administrator at the Apopka campus, and Lori Boardman, who was previously our chief medical officer for the Women's Hospital. We all attended a one-year course at Mass General Hospital with Joe Betancourt, and that really took us on the beginning of an organizational, formal journey and study towards health equity, and that really has culminated in Jessica and I now being here in the works that we partner as a DIAD leadership and lead for the organization.
Fantastic, thank you. So, Jessica, can you give us a foundation so that we can understand how we define equity and diversity and inclusion?
Marilyn, I'm so glad you tossed me that ball, because I'm going to toss it to someone in my midst who happens to have just completed coursework for a master's in healthcare management from Harvard. I'm sorry to embarrass you, Dr. Simmonds. But we're so proud, yes, so proud of what you've accomplished. And when you're having a conversation about health equity, it's so important to level set on common definitions. There's a popular saying, when you're talking about this work and you don't have common definitions, it's like trying to parallel park with one eye closed. So we're going to level set together, understand common terminology like disparities, health equity. What do we mean when we're talking about this work? And then we'll give you a quick overview of what this work looks like at Advent Health, and then we can engage in the conversation. Okay, Dr. Marilyn?
Thank you for that lead-in. So, Dr. Marilyn, you mentioned some definitions earlier, and depending upon what your source is for the definition, this is from the CDC, their Office of Minority Affairs, and it says health disparities are preventable differences in the burden of disease, injury, violence, or in opportunities to achieve optimal health by socially disadvantaged racial, ethnic, and other population and groups in the community. And so when you think about these things, this is further, it's meant to address the differences between population groups that are systematic, avoidable, and unfair, that removes obstacles so that every person has the opportunity to attain their full health potential and is not disadvantaged from attaining it because of all of these things: sexual orientation and gender identity, primary language, your social class, other social determinants of health, of which many of us are very familiar: housing instability, food instability, health literacy, and access to care. So when you start thinking about how disparities affect patients, did you know that blacks feel that they are 22% of blacks say that they are less likely to receive pain meds than their non-black counterparts? Or did you know that 70% of transgender patients feel as though they are discriminated against at the point of care? If patients have a disability, a physical disability, they're 2.5 times either to delay or to skip their care because of all of the effort that has to be put into the transportation and the arrangement for it. If you give care and it is without proper interpretive standards and communication, that your length of stay is actually longer by 1.5 times. 20% of women say that they feel as though their clinical concerns are ignored. We know for a fact, those who practice medicine, that women who have a heart attack and men who have a heart attack can present physically very, very different. The typical symptoms of left arm, left jaw pain, nausea, and vomiting, women don't present that way. And so we've got to be very intentional about understanding and thinking about that patient, realizing that the clinical presentation may differ dramatically just because of their gender. And obese patients feel that 28% of them feel as though their providers spend shorter time with them, and 50% of their readmissions to the hospital are actually caused by some of these drivers, these social determinants. Many of you have seen this picture, and it talks about equality versus equity. And I hear many of my colleagues in the operating room say, well, I treat everybody the same. And that's part of the problem. And Dr. Marilyn, you mentioned participate in some of that. What we really and truly need is for each person to get the kind of support that they themselves require so that everyone has equal access. That's equity. So if I give everybody one box, that's treating them equally. If I give everyone the support that they need, that's equity. And ultimately, if we remove the barrier, that's justice. Right? Some would argue that you have to actually remove the fence and just give everyone the ability to play the game without any physical barriers. Right? Yeah, that's a whole other talk. So our work at Advent Health is really a tripod, if you think about it. It engages the community, it engages our workforce, our team, and then the part that I'm really leading is our clinical outcomes. And this is in line with our service standards, and it is certainly engaged and surrounded by our mission to extend the healing ministry of Christ. So again, we've been involved now in these three pillars. Jessica, do you want to comment on any of this at all? No. Fine. So for the second time, 3-year commitments to really do these works. Every campus within Advent Health is going to be setting up a local DE&I council. We have done some work to set up a methodology that we've had vetted by a third-party population health specialist at the University of Massachusetts to be able to give each campus opportunities where disparities in outcomes may exist within the walls of the hospital at this first glance, and then the opportunity to engage our community in our every 3-year community needs assessment. So the goal here of these 3 pillars, clinical outcomes to reduce the disparities at the point of care, the community to address these conditions that are largely the social determinants of health when we can, and then in our workforce to reinforce the E&I efforts in our team representation to ensure that each member has the necessary requisite skills and competencies so that they can succeed. So just wanted to drop that as a little bit of a background about that.
Fantastic. Well, thank you so much for providing that background and for your leadership in bringing this forth and engaging the system really in this conversation. So you mentioned the importance of your team members. Can you talk about how you have engaged them in this work, the competencies that are required as well?
Absolutely. You know, what's interesting about the work of health equity is that we've often heard the language around cultural competence, right? How many of you are familiar with that term? Cultural competence is what we've been looking at to have our organizations have the skills, the training, the processes in place that recognize that people of different cultures, faith, etc., experience healthcare differently, and we can tweak some things about our delivery to make them feel a greater sense of belonging. The catch is there's sometimes a problem with cultural competency in that you might think that it has an end state, that learning, you can know enough about someone's culture. There's a story I'll just quickly share. Dr. Ada Stewart, she's the chair of the American Association of Family Physicians. And she talks about a 6-year-old Black woman that came into her office visibly upset because she felt that she had been mistreated from the time she walked into a subspecialist office. She said that she was assumed to have had her heart condition because she had a heavy diet in fried chicken and Southern foods, when in fact she had been a vegetarian for most of her life and took nutrition and physical activity very seriously and incorporated it into her daily lifestyle. But her subspecialist, the physician she saw, assumed that based on their cultural competence of that condition and what they knew of it, that was why she had the situation. And these are the traps that we can sometimes fall into when we stop at cultural competence. And that's why in industry, and this is what we're working on in terms of training and educating our staff, we're starting to move toward cultural humility, where we recognize there is no end state, but this is a lifelong journey and process of learning. How we can never know everything there is to know about a culture. I'm a Black Caribbean woman, and I don't know everything there is to know about being a Black Caribbean woman. And so we will never assume that, but rather through a journey of listening, continuous learning, we want to, in a humble way, engage with our patients while having important references of knowledge that can help us to treat them well. So it's a journey, and that's what we're working on with our team. Leadership learning, setting the tone with leaders, and then broader team member training. Anything to add, Dr. Simmonds?
No, I mean, I think that was a wonderful way to respond to this, the question. You know, one of the things that I think is important is when we talk about cultural humility, understanding and going deeper with the knowledge of another culture does not diminish your own. And I think that has to be called out. A lot of times people want to do this work, and the first thing they say was, oh my God, I'm being impugned, or I'm uncomfortable. And the reality of it is sometimes being uncomfortable is okay. Right? I don't know if any of you have ever walked into a trauma bay and seen someone bleeding all over the place. That's not the most comfortable of an environment for someone who's novice to it. But people do trauma care every single day, and they're very adept at it. And if that is life and death, well, this is life and death as well. This is what we're talking about. We're talking about dismantling barriers and giving everyone opportunities. And it takes courage. Leadership takes courage. It takes a boldness. And that's what I think is very, very important. So we face leaders who find themselves at very, very high pinnacles of their career who've not been exposed to this yet, who feel inappropriate in having the leadership competency to speak into these spaces. And we're running as quickly as we can to fulfill some of that competency so they feel comfortable with their hands on the lever, not undermining their authority or their leadership or their training or that of leading their teams, but giving them the ability to say, hey, I need to understand this and I need to understand it in a better way. The last thing that I would say in terms of leadership is we've got to be very, very careful to keep the community at the center of this work. And that's why I really, really love that kind of tripod approach. Because if not, you run the risk of taking on the savior mentality, where we as the big Emerald Tower, Ivory Tower, know what is best for the community, and we go into the community saying this is what you need without their say, without their buy-in, and those efforts fail. And so, again, that same level of cultural humility that we must have to lead our teams, we must also have with engaging in the community as well.
Yeah, thank you for that. The engagement of your multiple stakeholders who also have multiple identities, as you inferred. Talk to us about what some of the challenges might be in getting this collective to really work together, considering that we have been dealing with, political backlash. We've been, of course, racial unrest. How do you kind of manage those kinds of conversations, those difficult conversations?
Well, I think being a surgeon, being a clinician, we're dealing with health outcomes. And I don't think that anyone would argue with saying, or if the data, you follow the data, right? And if the data tells you that 3 times the number of Black people died of COVID than non-Blacks, or 5 times the number of Hispanics, you've got to look at why, right? That's part of our job. As I mentioned earlier, epidemiology is part of the job, right? And the other part of that I would say is even if you're not clinical, but you're an operator, you're in operations, you can't manage what you're not measuring. So you have to, again, develop the muscle memory to start interrogating your systems so that you have the greatest opportunity to have the best outcomes possible. And you've got to, again, be courageous. You've got to have a great deal of humility. And then you've got to remain open-minded. The way that I like to think of this work is this is a continuous quality improvement process. This is not about deracinating or stripping down or breaking down anyone's view of themselves or linking them to any ancestry. Or this is not, that's a bias that people come into this framework with. And so part of it is that we've got to remain humble enough not to be triggered when folk try to pull you down into that pathway. That's a rabbit hole that is devoid of energy. And so you've got to stay above the fray. You've got to continue to use your knowledge, use data, and then use as much evidence-based things as you can with participation with the community. And then you also have to realize that you're taking an organization and a group of leaders on a journey. And the journey takes you in different places. So our journey began realizing where we had gaps in data, right? Where we didn't have outcomes. We had large populations of patients who were recorded as unknown or unable to be determined. And we had to bring a lot of stakeholders together to close those gaps, and we were able to do so. But it took time. And I think those are the kind of things that I would say about moving stakeholders in a direction is knowing where you are, knowing how you're going to respond to certain things, and then having the empathy to understand that everyone begins their journey from a different place, and you've got to bring them along the journey with you.
Dr. Simmonds, that's huge. And as you're talking about the courage it takes to do this work, I have to commend and affirm our Advent Health CEO because he took the courageous step of making this work a performance accountability, holding our executives accountable to driving forward the work of health equity. And I do think that is a big part of setting the tone and igniting momentum behind this work because it married with having the evidence-based data, it really propels the work forward. And that's the thing about the data. You can certainly look at those health equity data points from across the nation, as Dr. Simmonds just shared. But when you can strip back that data and see what's happening in your backyard, in your hospital, that really localizes it and personalizes it. And I think that's another way that you can overcome some of that resistance. But I do want to recognize that first part of your question, Dr. Marilyn. There is sometimes for many people, I thought Dr. Ted did a great job of outlining this earlier, depending on the perspective you had, your lived experience, your reality, whether you have a religious perspective, a legal perspective, et cetera, the way you view this issue could be very different. And for many people, it can be a political issue. And I've seen the struggle that some of our very own team members have said when, I know America to be fair, just, meritocratic, and it's a meritocracy. And that's where people often struggle when they're seeing, can this data be real? And is it the result of somebody's difference, or could it just be an abnormality? And really using the data to have those honest conversations, to be vulnerable, because I really love a quote from Isabel Wilkerson. She's a journalist and an author. She talks about how ignorance is no protection from the consequence of inaction. And really making sure that we wrestle with the data, wrestle with the meaning of the data, and have those difficult conversations because for a lot of people, it's really transforming even your belief systems about the world when you do this work.
Wow. So I bet there are lots of questions about the evidence-based approaches, data-driven approaches as well that you use. And you mentioned the CHNA, right? So that's one example. So I'm sure there'll be some questions about that later. But I want you to talk a little bit about because there's a lot of work that you're doing, and I think we want to acknowledge that. But what are the things that energize you about the work, the day in, day out, right? You've got to keep it going, but what energizes you about the work? And then to contrast, what are the things that keep you up at night?
I think the things that energize me are seeing team members get it for themselves. When you see a CEO who is initially almost paralyzed, thinking of the fact that patients based upon their primary language or the color of their skin may have a different chance of life or death, and then getting to the point where he or she is now driven to action with a sense of immediacy, that's energy. Things that keep you up at night, we lead very, very high-performing teams. Advent Health just won an Emerald Award. I think one of the first ever, Dr. Goldman, the first one ever, first ever from Leapfrog, which is a safety rating agency that gives all of our safety scores. So this is a very high-functioning, high-performing team consistently. CMS 5-star, Leapfrog A. And to then say to this team, hey, we have opportunity to still improve more, right? And now we've got to talk about it in a way that may make us a little uncomfortable, right? In a social and political climate that, if anybody's been watching the news, is well aware of right here in the state of Florida. But we're still called to do that. So that can keep you up at night, right? Not getting the desire to not get caught up in this geopolitical rabbit hole, but stay very, very focused on the patients who are entrusting us with their guardianship. And I would say this, I would even say that I think it takes a great deal of courage to place a conversation about equity in an ethics dialogue, right? I've had the opportunity to work with Francis Nash and Dr. Lampkin and Dr. Leone as we ramped up and became educated about concepts such as autonomy, non-malfeasance, and beneficence. And if you can't talk about that in the context of people who are dying disproportionately or facing injury or readmission or complication at higher rates than others, where else does that need to be seated? So I also want to recognize this room for giving us this space to breathe this in from.
Agreed. And to that end, I would say what excites me, what energizes me is the passion, the grassroots passion coming from our teams. Dr. Simmonds and I could tell you, we get emails every single day from team members, community members, eager to be a part of this work, eager to share their story or their example or their idea of how we can address disparities. And the ideas are so diverse, multivariate, and it's so energizing to see how extensive the partnership for this work is, whether or not they're direct members of our team or we would be leading them through influence. And that has been just truly energizing and continues to be the wind beneath our sails. And what I would add about what keeps us up at night is moving this work from, and now I'll say this for myself because I'm very confident that we will accomplish this, but one of the criticisms this work has gotten in industry is that it's been very theoretical, but has not often shown results. And a lot of times the results require partnership with community. Because remember, somebody brought this up earlier yesterday when Dr. Smith was speaking. A lot of times we observe health disparities because of things that not only happen within our four walls, but things that happen outside. Food insecurity, access to transportation. If somebody can't get back to the hospital for their checkup, what is their likelihood of falling back into the state of disease? So that is what we're grappling with, something that's much bigger than what somebody's receiving at the point of care. And just really getting our arms around the scope and around the right actionable levers so that this work is not just aspirational, but that it's also executable is something that I just take very seriously. I don't want to say that it only keeps me up at night, but it's something that drives me further to work really hard at the work.
Right, so you've covered a couple of components of building that culture of equity. And then Dr. Simmonds, you mentioned ethics. So can you make that connection for us about how ethics fits into building a culture of equity?
Well, I think if you just take those three terms that we talked about, the patient's autonomy, their ability to feel whole within themselves, their ability to trust that no matter how I show up, black, white, brown, or zebra, that my care when I'm ill will be the same, right? That no harm will come to me because of the color of my skin, right? So you replace Tuskegee and a number of other things, right, where that has not always been the case. I think that builds an enormous amount of confidence in the society as a whole. And healthcare anchors the society. There's no doubt about it. From our first breath to our last, we are part of that. And I think that is, in my mind, benevolence. How do we make an act for people who don't understand the risk that they are taking and how it may pertain to their illness or their pejorative outcome? How can we benevolently advocate for them on their behalf? Those are all ethical principles. And I think if we can ensure that healthcare providers are coming into it with that kind of a mental construct, not just the stethoscope to the chest, not just the prescription pad, but literally the way that you are approaching the patient with your cognitive state of being and the knowledge that we have. Physicians and healthcare providers are in an incredible, powerful position, and there's a great power disparity between the doctor and the patient for a number of things. We get to do things that if I didn't have an MD behind my name, I'd end up behind bars for. I've been cutting people for the last 20 years, and they pay me for it and say thank you. I mean, for the right purposes. I don't want to but point notwithstanding. So I think that those are some of the ways of which equity and ethics really are firmly entrenched one with one another.
So there's a lot of work that's put on clinicians, in particular in this work. Talk about that intention, and I think sort of that intention of moving from the awareness, right? So understanding what the disparities are, how they're affecting the communities that you serve, to the action. Give us some examples.
So one of the meetings that Jessica and I have tomorrow is with our Corporate Diversity, Equity, and Inclusion Council. And for the first time, we will share with them the data from the dashboard that we have put together and the methodology that we have used to determine where inequities in care exist. And they are spread across health dimensions and health outcomes. And so for one of the first times, to my knowledge, a large healthcare system will look at outcomes across the dimensions of complication, mortality, length of stay, and readmission. And we will look at those through the lens of race, ethnicity, gender, and payer status across a wide array of diagnoses. And we're now looking to see whether or not there are outcomes that are not on par one with the next. And we're seeing that. So the question is, now that you become aware of it, what do you do about it, right? And the first question is, well, one, become more curious about it, right? Are all these patients being treated in the same way? Are they all being treated with an evidence-based pathway? Do they all live in communities where they have equal access to care? Where there's equal distance from a primary care doctor's office or to the medications that one would prescribe? And further than that, I think the work in the future that takes this from aspiration to reality is not simply understanding the outcomes of the care that they're receiving, but their own perception of the experience of care that they're receiving. So I am curious to know, we have patients who leave against medical advice. I'm curious to know if there's a racial or gender predominance to that, right? And perhaps does that inform that I don't feel cared for, so I'm leaving you in this hospital even when I'm so sick that I've come here by an ambulance? I'm curious. I'm not saying that exists, and I don't want that to be misconstrued, but I am curious, and that's what we've got to do. We've got to become curious to flip the rocks over and see what roaches run out from under them.
And I just want to acknowledge one thing that really works about the Advent Health model is having a physician leader in the role as the health equity officer. You talked about the stake that clinical leadership plays in this work, and having Dr. Simmonds' voice as somebody who understands the lived experience of what it means to lead a clinical team. By the way, here's Superman. He's Chief Health Equity Officer by day, but he's also the Chief Medical Officer of one of our local hospitals. So he understands the operational aspects as well as the broader strategic aspects of this work. And that is so helpful as we infiltrate the consciousness of our workforce around what the next steps are. And that's been the key here. Eventually, I'd love for my role, Dr. Simmonds' role, to not exist. But how do we integrate this so that having people experience equitable outcomes is just part of our quality work and safety work, where we're having cultural responsiveness embedded into our community health needs assessment, where we're asking questions about social determinants of health, anything that affects your reality and experience, making sure that that's weaved into our community practices, our engagement practices. And that's the goal of what Dr. Simmonds and I have been working on. How do we embed ourselves in our supply chain teams, in our community teams, in our clinical teams, in our HR teams? It's really been across the entire organization and helping everyone learn the exciting role that they can play to advance this work.
I sit here and I smile when she says Superman. I think of my 14-year-old daughter who, every time I tell her I'm speaking someplace, just cannot understand why anybody would want to sit in a room and listen to her father. That's mystical. Kids keep you really humble. No, I think to your earlier question about what we're doing to advance the work, how do you take it from an aspiration? We get to work with the academy, and we are part of an equity alliance, one of their inaugural partners, financial contributors. And these are all healthcare systems that, in order to be involved in this group, must be present in at least 3 states. And I think the cutoff is $1 or $2 billion of total dollars in revenue. So these are the Sutter Healths, these are the Intermountain, these are the Cone Healths, large healthcare systems who are really grappling with the exact same things that we're talking about in this forum. And that allows us really to be really at the edge of this tilling soil as we're doing this work. And testing best ideas on each other and pressure testing them as well. So that's another place where we get to do it, is we get to be a national lead, right on the vanguard of the change.
Yeah, definitely leading the way. So tell me, in your interactions within this collaborative, what are the lessons? Just what are like top 2 or 3 lessons that you can take away from that you can share with all of us today?
One is, don't assume that because it's clear in your mind that it's clear in anybody else's. Yeah, that's a downfall of being a surgeon too. So I come out of a career where you put your hand out and ask for an instrument and you don't have to look up and it's there. You say it once. And this work requires continuous repetition. And in fact, each opportunity that you get to repeat it is actually wind behind your sail. So it's a reframing of any context of which you have come into the work previous, whether it is sending an assignment back to a student with red ink and telling them you want them to rewrite it, or whether it is understanding that each platform that you get is an opportunity to further influence the hearts and minds of other change agents. That is one. Second, I think do not underestimate the amount of time that it takes for real change to become materialized. So if you say, well, what have you been doing for the last 2 years? What inequities have you closed gaps on? I would say to you, I'm not quite certain that we've closed the gaps on any, but I am quite certain that we've built an apparatus that allows us to look at where they may exist. And it takes that time. It takes that time and the commitment and great resources to gain data, to put together a true race and ethnicity table that you can query, to put together computer-based learning pathways that can explain to patient registration team members why it is important to gather accurate race and ethnicity data at the time of patient registration, garbage in, garbage out. So don't underestimate the amount of time that it takes. And thirdly, I would just say that there are others who have based their entire equity work outside of the walls of the hospital and more in the community. So don't feel that you have to start at any given one place. You start where you start.
I'll just add one more, and it really echoes what Dr. Simmonds said. There is the work and the aspiration of health equity, but so foundational to it is the culture of health equity. This work is as much change management as it is the action of closing the disparities. And that culture of health equity begins with aligning people with a shared definition of what we mean by health equity, what our organization's value is going to be placed, the value that is going to be placed in closing health equities, what it means to us, how we're going to do it, just really getting everybody along the journey, believing in that is a huge part of the work. And part of that work is setting the tone from the top. Leaders have to set the tone, and one of the first rules of that is good leadership is inclusive and equitable leadership. To be a good leader, you do have to be a leader that achieves equitable outcomes, making that part of what's the definition of leadership, to the point when you're designing your leadership development programs even, making sure that this work isn't seen as separate from leadership development, but very much so an integrated part of what it means to be successful in the organization. And that's been our journey as we think about our current leaders who are saying what they wish they had learned before being faced with this work. And now we're trying to activate that as we're maturing new leaders in the organization so that they can be in an even more advanced place of readiness as we pursue this work in the future.
Thank you. I completed this 8-month, 9-month leadership program called Race Equity Action Leadership in our county, and I remember in the early sessions having a lot of information about inequities, the historical injustices that have affected marginalized populations for hundreds of years, and thinking, how do we hold on to the hope? Right, so we would talk about how do you hold on to hope in the face of brutal facts. And I think in what you are presenting is along the themes of the conference that we're participating in today. So tell us about, or give us a message. What's the message of hope that we can take with us after we leave here today?
So it's interesting. A week and a half ago, I was privileged to be the keynote speaker for Adventist University's graduation, and my closing statements was largely a story. I told a story about being a young intern on surgery and a patient having a very aggressive cancer called laminitis plastica, for which there's no cure. And we went in 5 a.m. in the morning and made rounds on the patient, and my attending, who was a very esteemed professor, said, "Simmonds, what do you want to do?" And I said, "Sir, there's nothing else we can do." And he reprimanded me very, very briskly and said, "No, young doctor, you can always give hope." His words were that when you give the gift of hope, you always give the anticipation to the patient. Right? They can always anticipate the joy in the fact that hope is not extinguished. And so that, I've never forgot that interaction, that exchange. It was literally my first day as a doctor, if you will, knowing nothing. And so I think in the same context, we must always have hope. We sit here today, West Indian children, very learned, in positions that my grandparents could never have thought would exist today. And we use our platform and our voice to advocate benevolently, ethically, for change for a community in a society that sees a lot of darkness and that gets lured into disentangling ourselves from the plight of other human beings. And we have one earth, and all of us are privileged enough to be citizens of it. And this work is really just about talking about how we do that better. How do I preserve your health? How do I give you the best opportunity for health so that all of us can have things to hope about, so that you can have the creativity to create things to hope for. So in my mind, and the mind of the poet as well, and I can't remember who said it, but hope springs eternal in the chest of man, right? And I think that's still true today. I'm very hopeful.
I love Dr. Simmonds' story, and it inspired me. And so I won't belabor this, but I find hope in you, in the partners, in just the passionate people who are committed to the work of health equity. It feels like the time is now. the zeitgeist, the stars are aligned. And I love a quote by Mahatma Gandhi. It's not exactly related to this, but it reminds me of something that I find inspiration in. The best way to find yourself is to lose yourself in a life of service. And I feel as though the genuine passion that the people working on this work have for it, it's starting to reveal the answers along the way. We're beginning to find our way. We're beginning to find how we can press through to make our aspiration a reality. And just the actioning every day toward that aspiration gives me hope. We're one step closer every single day. And I'm just so grateful to have the partnership of Dr. Simmonds, to have the interest and partnership of all of you, and look forward to continuing this conversation with you.
It's wonderful. Thank you. Let's give a hand to our speakers today. So I'm going to open it up for questions, and I'll be happy to bring you the mic.
Thank you so much. That was so insightful and excellent content. I was thinking about this conversation of equitability, and I think one of the things that is coming up and that hospitals might be struggling with is that standards of care across different conditions and diagnoses do not allow the nuances of the equitability that some of our marginalized populations have, and things like inaccessibility to transportation or certain insurance coverages and things like that then standards of care don't allow space for. How do you create the space for standards of care on unit floors and hospitals in general to be destabilized in a way that would allow for considerations of the equitability that many of our patients face?
That's an excellent question. And I think there's a couple of different ways that I would look at it. One is what's going to be disruptive and what's going to be innovative. And either we get to control that or we'll be judged by it. So U.S. News and World Report, they have put forth candidate questions that speak exactly to what you were talking about. Access to care. Outside folks want to know, particularly for not-for-profit hospitals, what is your revenue to community spend ratio? There's an expectancy that we're investing in the community, and that is why we're receiving the benefit of being a not-for-profit. So outside agency will look at that. CMS is putting forth in their latest ruling things around equity as well. And the second way that I would answer that is that, there's a science to medicine and then there's also an art to medicine. And I think some of what this is about is that art of medicine, right? Is that humility to understand the community where they're coming from, to know a little something about that zip code or that area where that patient comes from, or to know that there's not pharmacies there, or to understand the impact of where that patient lives and how far beneath federal poverty level it is, and to do special things about that. And so, so I think that there is, the innovation piece just requires, folks to come up with new and unique things that bend the curve. And if we want to be successful financially, that's what we're going to have to do. We're going to have to be disruptive with technology, not in a bad way, but in a good way. Something that disrupts the status quo, that disrupts the fact that more people of certain colors are dying of COVID, historically, right? Those are disruptions. Telehealth and wearing biologic heart monitors and caloric things and pedometers and all those kinds of things. Those are the kinds of things we've got to really think about in special populations and make it available to them.
I'll quickly add, so my background is in org transformation. I'm a former management consultant, and you are asking the money question when it comes to change management. This is what I was referring to earlier. The work of building a culture of health equity truly is transformational change, and you need to look at people, processes, technology, the full organizational scope to make it a reality. And so what I would recommend is, as you're truly building out that health equity plan, there may be a justification for a person or a committee to be dedicated to the work of reviewing policy. We're even doing some of that work at Advent Health to understand, who does this policy impact? How does it impact different groups of people in different ways or burden them in different ways? How can we reimagine it? And it's a lot of work. It's one of those projects that can be multi-year, especially if you're going through each one. So there's a prioritization exercise that probably would need to lead that. But I do want to encourage you to lean into the work, because you're right. A lot of those standards are a good place to start to give everybody a level setting. And it's a good thing to start sooner than later, because it's a long journey for going through all of those.
Jessica, I was interested earlier when you mentioned that equity, you've been able to build it into being a performance point, and accountability point, because I think until you can't measure it, then you can't hold people accountable, and then it doesn't become mainstreamed. But I'm interested to also know if you could just tell us a little bit about that program and whether you've been successful to move it beyond just a transactional outcome-driven thing, or whether you've also been able to actually measure, cultural development as part of those performance factors.
So I would say that all of the things that we're doing, these short-term incentives, are brand new. Really bold leadership on the part of Jessica and the teams that she influences and leads, and Alicia, our chief HR person, and Terry, Shaw, our CEO. Those accountabilities don't even come due until December, the Q4 of this year. But your point is spot on. When you talk about changing culture, you can't just do a one-off. You've got to really check in with the culture and the climate and the temperature over time. In my mind, I think we'll know we've gotten there when folks are not waiting on a financial reward to do the work. In my mind, this is a scholarship in health equity, if you will, that allows executives to really develop the muscle memory to do the work and to gain some real experience in it, incentivizing the change that you want to be longer lasting.
And I wanted Dr. Simmonds to answer first, but he's absolutely right. We are in the midst of our first year, so we'll be a good case study for you. What I will say is, you nailed it. Even when we're meeting with teams, there's a lot of high touch, high interaction engagement that we're doing with the teams that are executing on this. That's the most frequently asked question. How do we make sure that we're not just checking the box, but that we're leaning into the spirit of this work? And a lot of it has to do with readiness and making sure that leaders feel ready to engage. And so there's been a huge part of this campaign that's around learning and giving leaders the space to be uncomfortable together, to ask questions together, even when they're quote unquote the wrong question, the one that we shouldn't ask. I'll give you a quick example. In meeting with some of our senior leaders, some were surprised to learn that, hey, they don't know what the definition of gender fluidity is, or other terms that may be important for the language of health equity, but may be very unfamiliar to a leader who has not been immersed in this space. And we realize that sometimes leaders are uncomfortable with even sharing that they don't know. And so we are trying to create the space so that leaders can collectively learn together in safe and brave spaces, spaces where you can be vulnerable, where we can actually understand where our health literacy gaps are so that we can provide more of that content, while we're at the same time activating these DEI councils and health equity plans. So there's a lot of designing and building happening at the same time. But what you said is really important, creating the space for that vulnerability and that immersion into exploring your own self-awareness of these issues. That's been a huge part of our journey.
I have tremendous faith in this organization and the DEI initiative, councils, all of it. I've been following and I love it. And I think the reason why I have faith is because we're kind of a closed system, so we have a lot of opportunities within a closed system to continue to educate and engage and create even smaller safe spaces. But my question is the challenge of reaching communities to get their input, especially in a diverse community such as Central Florida. What are some of the strategies that we're using to gather that data? Not so much the data, because the data can be collected by patient registration, by information in the EMR, like all of that, but the actual like town hall kind of format, or the engaging in live discourse, because very often, you know, the marketing for that, getting people to come to those events to represent their communities and engage is a challenge. Also, if it's a once a year, once a 3 year. So I'm very curious to hear, how are we reaching out to communities for their more open-ended input, not just data points?
I'm so glad you asked that question. And this gets to the integration we talked about earlier. I'm so glad my colleague, Mike Griffin, and Sarah, I saw him earlier. Oh, there you are, yes. And we work closely with his team to integrate in to our community health needs assessment work. And here's what we mean by that. You're right. Dr. Simmonds and I met with that team early last year because we realized that this year, 2022, is actually a CHNA year. We're doing the assessment. And not only did we work with them to include and embed more thoughtful questions about how DEI themes show up in their world and their realities, but we're also looking at how this won't just feel like a once every 3 year stop on your calendar. We're going to try to build out that engagement plan so that there's more trust in the community. We just actually did a pilot training called Inclusive Environments of Care with the community benefit team, the group that's responsible for engaging with the community and building that long-term trust. So I do want you to know, and I'd love to connect with you after because I can hear your passion for this work, that this is exactly the direction we're going in, engaging the community to be a partner in the work so that we're not falling into that savior mentality, right? And determining what they need. Is that humility of listening to them and letting them tell us what they need and partnering with them in creating the experience that they will buy into.
You know, I would also add to that, I think that, the vaccination hesitancy that we had to address during COVID was a wonderful exemplar of large healthcare systems going into churches where we knew that communities, whether they were meeting virtually or not, had great deference for their spiritual leaders and the ability to influence them through that means to get vaccinated. So there's clearly a synergy between spiritual health and physical health, and I think we've got to continue to tap into that. There's also another example with Tim Cook, who's the CEO of the Altamont Hospital, and Dr. David Sinclair, who's his CMO. We got to do some work with them in a series called Finding Hope. And it started with vaccination hesitancy, but then they took it beyond that, and they actually went into a Sikh church and a Spanish-speaking Christian church and an African-American church, and they interacted with the congregants, not just with the pastoral leaders. And it was actually really fascinating. I mean, it shouldn't be fascinating, but, like the Sikh community said to us, hey, you guys think we don't know that when we walk in with the turban on that we look different? Like, we're well aware of that, like they get that. But then beyond that, they said, when it comes time to deal with issues like end of life, why don't you come to where we worship? Because that's where we feel comfortable, right? We start life there. We have to have a conversation about ending life. The place to do it is not with things beeping and, tubes and wires and all kind of speak about medicine that we don't really understand. Why don't you come back and have those conversations with us? So, the Hispanic, Spanish-speaking congregants that we spoke to, they talked about the difference of having a translator who was there with them, who could touch and feel and speak to versus an iPad where it's communicating through, right? Mm-hmm. So it's these kinds of things, and that's at the point of care for the patient. But we've got to get to the point where that is a continuous operation and not just happening on an individual when you're so sick that we've got to intervene or we've got a pandemic happening and we need to. We've got to do more of those kinds of Finding Hope type series to anchor hope and keep it.
Thank you, Mark Carr. As an ethicist, I'm encouraged, and I thank you for engaging us. I want to recognize also, and thanks to Dr. Winslow for drawing together elements of the church administration and elements of the healthcare part of the Adventist tradition. There is naturally going to be tension. What I'm hopeful about is you're leading us into significant diversity, equity, and inclusion conversations. Presently, the General Conference has a position about transgendered persons. They cannot be members of our church unless they're celibate or pretend that they're one of the other binary. Do we have any hope that you, from the healthcare perspective and from the work you do, can you lead us in a more just and appropriate way?
Help me, Jesus.
No pressure, Dr. Simmonds.
Hey, grandma told me to pray. I mean, it still works. No, I mean, in all seriousness, though, I think there are standards of care for LGBT communities from a clinical standpoint. And the reality of it is that patients who are transgender, who are LGBTQ, they have certain physiologic issues, like a 3 to 4x rate of suicide in the general population, right? And so I don't know that I am the right person to lead doctrine of the church. What I can lead is an organization who is responsible for the care of all of God's children, to develop, again, that cultural humility to recognize that this is a person who is suffering and in pain, and they have a higher prevalence of certain type of diseases if we recognize that, right? So the spiritual confluence is not mine to judge. We're a hospital, right? And I think if we're a hospital who is stating that we are extending the healing ministry of Christ, well, then the rest is obvious.
Thank you so much for your presentation today. I'm going to ask everybody, the next time you go outside and you see those bike racks with all the same bikes on them, just think about how somebody who's 4'9" or 6'2", or somebody who's in a wheelchair is going to access that resource. That's the thing to remember. We want to look through that EDI lens. All right. Thank you very much.
Thank you.